In this video, we're going to be looking at the oculomotor nerve, the trochlear nerve, and the abducens nerve. My name is Bryce Pugh. I'm in the class of 2027, and a lot of these drawings and resources are derived from the SCRUBS drive, or the SCRUBS resources, so be sure to check those out. Also keep in mind that this is all student-made and student-compiled, so there might be some errors in here. I did my best to follow the course pack, but be sure to use that as your primary resource. So let's begin by looking at the cavernous sinus. So we talked a little bit about the dural venous sinuses and the vasculature of the head and neck, but the cavernous sinus is going to be right here. So let's take this little pane out, this window pane, and look at it closer up here. So we have our sphenoidal sinuses and our pituitary gland, which rests in the hypophyseal fossa, and then on either side of that is our cavernous sinus. Here's a simpler drawing, just to make it a little easier to remember. We have our pituitary, our sphenoid sinus, and then our cavernous sinus on either side. The cavernous sinus contains cranial nerves 3 through 6, with the exception of V3. So we have 3, 4, V1, V2, all on the lateral wall of the cavernous sinus. And then 6 is going to run a little more through and medially, along with the internal carotid artery. It's also worth noting that the postganglionic sympathetic nerves have a plexus that's going to run with the internal carotid artery here. And the superior and inferior ophthalmic veins are going to drain into here, into the cavernous sinus. This is significant because in infection, we can get infection draining into here, and that can affect the nerves and cause engorgement of peripheral veins that connect with it. Here's another just like quick drawing if you like to remember it this way. So you can remember O, Tom, the cat. So we have O, Tom, cat, and that stands for each of the nerves and components. So we have oculomotor, trochlear, ophthalmic, maxillary, and that's going to be the lateral wall. And then we have internal carotid and abducens are going to be on the inside. And so the reason that these three nerves are grouped together in the course pack is because they're all going to be going to the eye, and to get there, we're going to be traveling through the superior orbital fissure. And so if you remember, that's just inferior to the lesser wing of the sphenoid bone. So they're going to travel through there. Here's a picture of an inferior view of the brain, and this is just showing where each of the three nerves comes off. So we have oculomotor, trochlear, abducen. And so before we look at the nerves, they're all going to go to muscles of the eye. So it's good to have an idea of what the muscles of the eye are. And so we have these bottom 6 are the muscles of the eye. And then we have this one that's also going to be important. So this is the levator palpebrae superioris. It's going to come up here above all of them. And it's important because it's really involved with the upper eyelid. And so it's going to keep the upper eyelid open and lift it up. You can remember that because of its name. We have superioris, so it's up here on the top. Levator, it's going to lift the upper eyelid. And palpebrae, so your eyelid is kind of like a palpitation or a blink. So it's going to lift the blinking upper eyelid from a superior point. And then looking at our 6 muscles of the eye, we have 4 rectus muscles and 2 oblique muscles. So rectus comes from a Latin root that's like straight. And so all of those are just going to be straight for the most part coming off the eye. And so those are going to be named based on where they are. We have our superior, our inferior, our lateral, and medial. Medial is going to be more medial, so that's closer to the nose. And then we have our 2 oblique muscles, and they're named that way because they're more oblique and a little curved. And so we have our superior oblique, which is on top of the eye, and our inferior oblique on the bottom of the eye. And so I'll also point out already in this picture, we can see this little like a hook that the superior oblique is traveling through, and that's the trochlea. And so that's where the trochlear nerve gets its name. As you can imagine, it's going to go to the superior oblique muscle, which runs through the trochlea. So we'll look at the trochlear nerve first. Here's a simplified drawing from the Scrubs drawings, but also the course pack, and I kind of mushed them all into one just to give you a simpler view. And so on the top here we have our trochlear nerve. It's going to start from the posterior brainstem, pass through the cavernous sinus that we talked about, through the superior orbital fissure, and so now it's in the orbit over here, and it's going to go to one muscle. So we're only GSE, efferent motor innervation, one muscle. And so that's going to go to the superior oblique, as we just said, because that muscle is going to pass through the trochlea. A mnemonic that the course pack gives to remember this is SO4, so superior oblique, supplied by the fourth cranial nerve. So if that helps you, you can remember that. Here's the course pack drawing. You can see pretty simple. We have our trochlear nuclei. So it's going to come out through the superior orbital fissure to the superior oblique muscle. And I put this picture here just to further emphasize that we have our trochlea here. The superior oblique is going to pass through, and that's the muscle that the trochlear nerve is going to. Next, we'll look at the abducens nerve, which is equally as simple. We have our abducens nuclei at the anterior brainstem. We're going to pass through the cavernous sinus, through the superior orbital fissure, into the orbit, and then we're going to go to the lateral rectus. So again, we're only GSE, and we're going to the lateral rectus. And the mnemonic that the course pack provides for this one is LR6, lateral rectus, supplied by the sixth cranial nerve. Here's the course pack drawing. We start at the abducens nucleus. We're going to come out through the superior orbital fissure to the lateral rectus. We're only GSE components. And then the third nerve that we're going to look at, and the final nerve of the chapter, is the oculomotor nerve. And as you can see in the drawing, it's a little bit more complex, but it's really not too bad once you get it down. So we're going to start in the brainstem. We actually have two nuclei to consider here. We have our oculomotor nuclei, which just follows the trend of being named with the nerve, and that's going to have our GSE component. But we also have another nuclei, and that's containing GVE components. So the oculomotor is not just GSE like the other two, it also has GVE, and that's the Edinger-Westphal nucleus. And so those are both going to be in the brainstem, and then they're going to run together. They're going to pass, and this is where we become oculomotor nerve. We're going to pass between the superior cerebellar and posterior cerebral arteries. If you remember, those are around the circle of Willis, and they're a good landmark to identify the oculomotor. If you don't recognize that, go back and watch the previous video. That's vasculature of the head and neck. But it's going to run through those and descend into the cavernous sinus. In the cavernous sinus, we're going to have sympathetic postganglionic components join and ride with the cranial nerve. And so remember, we don't have any sympathetic components of cranial nerves, but a lot of times we see them riding with them just to travel to effector regions. And so that's all going to join us here in the cavernous sinus. And then we're going to pass through the superior orbital fissure. And once we're in the orbit, we're going to split. And we're going to have a superior division and an inferior division. The superior division, we're just going to innervate two muscles. So we're only GSE here. Just like the other ones, just GSE to two muscles. And these muscles are both going to have superior or superioris in their name. So the superior division, superior, superioris. One is the superior rectus. So we looked at that, the superior rectus, just the top straight muscle. And then the levator palpebrae superioris. If you remember, that's the one that does our upper eyelid. Then we can look at our inferior division. That's going to innervate three muscles. So we're going to go, and then the two components, the GVE and GSE, are going to split up. So our GSE components, which are just going to muscles in all of these, that's going to go to the remaining three muscles of the eye. So we're in the inferior division. We're going to have the two muscles that have inferior in their name. Inferior rectus, the straight one, inferior oblique, the curved one. And then we're also going to go to the medial rectus. And so if we go back up a little, we have our GVE components, coming off, so that's our parasympathetic components, are going to come off and become, and that's recognized as the short root of the ciliary ganglion. They're named that because they're going to come off in synapse at the ciliary ganglion. You should recognize that from the trigeminal nerve video or chapter of the course pack, where we saw that there was a ganglion that was structurally associated with each of the V1, V2, V3, but not functionally associated. And so the ciliary ganglion is attached to V1, and specifically at the nasociliary branch. And so this ganglion is specifically located at the angle between the optic nerve and the lateral rectus. And so this branch, GVE, short root of ciliary ganglion, is going to come off synapse and then continue out as the short ciliary nerves. And that's going to go to a couple muscles. And the sympathetic components that was riding with us, it's also going to come off here, but remember it's postganglionic already, so we're not going to synapse. The sympathetic is just going to continue straight through and go to the same regions. And so the short ciliary nerves are going to really go to two muscles that we care about. One is the constrictor pupillae, which you can probably imagine by its name, that's going to constrict the pupils. And then the other one is the ciliary body muscles. And so that's at the ciliary body. And what that muscle is really important for is like focusing your eye if you want to focus in to look at something. And yeah, sorry, so I grouped that off here. So the sympathetic component is actually going to be the one that goes to, it's not on here, but that's the dilator pupillae. So if we think about it, parasympathetic, that's our rest and digest. That's going to go to constrictor. Sympathetic, that's fight or flight. That's going to go to dilator. Here's the course pack drawing, so it's pretty much the same thing. We've got our two bodies, which are the two components. They're going to come out, go through the superior orbital fissure. Our superior division is going to come up, go to two muscles. Our inferior division is going to split by components. The GSE is going to go to these three muscles. The GVE is going to branch off as the short root of ciliary ganglion. Synapse at the ciliary ganglion, which is running on V1. And then the short ciliary nerve is going to continue off and go to those muscles. So now let's look at the movements of the eye. So we have all these muscles. We obviously know that our eyes can move in all sorts of complex ways. But to simplify it, we want to think about movement in three axes. So we have vertical, up and down, horizontal, left and right, and anterior-posterior, which is a little hard to visualize. It's kind of in these pictures too. That's going to be a little more like rotation. And those are heavily going to be focused on the more oblique muscles. So what can really help when thinking about these and what each one does is to consider their origin and insertion. And so you don't need to know specifically what, but just where they are. So if this muscle's here, all muscles do is pull. So if all muscles just pull, we're going to be inserted right here. We're going to pull that back. You can imagine the superior rectus is going to pull, and that's going to go up. The medial rectus is going to pull, and that's going to force us to go sideways. The curls are going to pull, and that's going to cause us to do sort of like a rotation. And so let's look at these drawings. So we have our primary position. Our eyes are just resting. This is left eye, right eye, or I guess it would be backwards, but we have adduction. So we're adding to the midline. We're going to the midline. That's going to be our eye moving, moving more medially. And then we have abduction. So that's our eye moving, getting abducted, moving away from the midline. So it's going to move out. So if you'd imagine a nose was right here, we'll have our adduction going towards the midline, abduction going away. We also have elevation, which is elevating, going up, and depression, which is going down. So these two are our horizontal axis, these two are our vertical axis, and then the sagittal or anterior posterior axis, which is a little more the oblique ones, it's kind of hard to demonstrate here, but yeah, we talked about what that was. And so the medial and lateral rectus muscles are going to move the eyeball on only one axis. So that's abduction and adduction. But the other four muscles, so the superior and inferior muscles, they are not technically parallel to the axis of the eyeball. So in this drawing, they look like it's just straight up and down, but it's actually off-laid a little bit. And so each of these muscles are going to have primary, secondary, and tertiary functions, but they're going to act on all three of these axes. And so what we're going to see from that is that for movements like elevation and depression, it's not as simple as just the superior rectus or inferior rectus pulling up or pulling down, because they're going to kind of have to work together. So this is grouped in this format. So you can kind of imagine those here, but like I said, I like to think of it a little more as like where they insert, what they do. And so you can imagine like our main elevation muscles are superior rectus and our inferior oblique. And so again, the oblique ones are a little hard for me at least to visualize, but they're going to be involved with elevation. And so when we have multiple muscles working together, ones that do the same function are going to collaborate to perform that function, and then any other functions are going to cancel out. So if we did superior rectus and inferior oblique, lateral medial rotation, that'll cancel out. Adduction, abduction, that'll cancel out. And so we'll be left with just elevation. Here's another drawing that you can study on your own a little bit if you want to just consider like more of the specifics of what muscle is doing what. We've got like elevation, depression, abduction and adduction is in both of these pictures. And then you can see a little bit more what the obliques are doing here. We'll look at a few clinical correlations before the video ends. So first, the oculomotor nerve can be compressed from an aneurysm in the nearby vessels. So we talked about those two vessels that it's going to run between. If there's an aneurysm there, that can compress the oculomotor nerve. And that can be identified because here. So here's our normal eye, because remember, bilateral. Here's our other eye. And so we won't be able to elevate or adduct the eye fully. So it's going to get kind of pushed out and down because those muscles will be paralyzed. So we can't abduct or depress. And this can kind of cause double vision. And sorry, I said that wrong. It's going to be abducted and depressed because it won't be able to go back the other way. So that'll kind of cause double vision is how patients will report it. That'll give us an inability to lift the upper eyelid, so that'll be drooped, and we'll have a dilated pupil that won't be responsive to light. And then the last three clinical correlations can be related to the other nerves, and then one more, we have the trochlear nerve. Interruptions to the trochlear nerve can limit depression of the eyeball, depression moving down. And patients with this will often report difficulty walking downstairs because they'll have trouble moving their eyes down. Next, with the abducens nerve, it can sometimes be involved in fractures at the base of the cranium, which is the skull. And so damage to the abducens nerve will prevent abduction of the eye. And then finally, we have Horner's syndrome, which is represented in this picture here. And that can occur from injury to the cervical sympathetic nerves. And it's going to result in a loss of sympathetic tone. And what that means is constricted pupils, eyelid drooping or drooping, vasodilation, and drying of the face.